Good morning. Welcome. We appreciate you being here on Friday morning. And I think this is edition number 4 or 5, John, of our clinical update series.
Big 5, yep.
5. Okay. We have 2 guests that Tom will introduce in just a few minutes, Dr. McGinn. And I do want to say that we are looking at the timing of these calls, and you may see some rearrangement over the next week or two. And we're actually going to be surveying some of our team to see how this can work better for people across the country. We span a 3-hour time change between California and the East. So we're looking at that. And we are also looking at these clinical updates have taken on a life of their own, which I think is a good thing. And we may add one more sort of normal business-like physician enterprise leadership team meeting monthly. In addition, we want to get restarted on our quarterly, what we call the Big PELM, the large physician enterprise leadership team, where we come together either in person when travel allows, or by Zoom before that time. So we have a brief reflection. John, if you'll bring that up, and then I'm going to turn this over to Tom. Okay, so this is in honor of Black History Month. And John, if you can go down, the author is, I think it's at the bottom, or no? Oh, here it is, Shyla Griffin. There you go. So I'll just read this. Many of us were educated in schools in which the perspectives, experiences, and discoveries of Black Americans were not an integral part of our learning. Too few of us know about the work of Fannie Lou Hamer to secure voting rights for African Americans, or about Ida B. Wells' leadership in the women's suffrage movement. Too few of us have learned about the efforts of labor leader Asa Philip Randolph, who worked alongside Bayard Rustin to organize the March on Washington. Too few of us have read the novels of Octavia Butler, the essays of James Baldwin, the poetry of Gwendolyn Brooks, or the plays of August Wilson. Too few of us know of the mathematical genius of Marjorie Lee Brown and Katherine Johnson, or the scientific contributions of Joseph Graves and George Carruthers. Instead, the narratives most of us have about Black Americans has led to inaccurate stereotypes, biases, and prejudices. Black History Month provides the nation with an opportunity to hear the voices and experience of people who have historically been oppressed, ignored, marginalized, and overlooked in our country. Black History Month is not just a time to celebrate Black Americans who have paved the way for all of us to thrive. It's also a time for us to consider how we can create more justice in our daily lives and institution. During Black History Month, let us pause and reflect on our biases, stereotypes, gaps in knowledge, and relationships across racial difference, so that we can be leaders in creating an education system, and I would say in institutions in general, in which equity, inclusion, and social justice are at the forefront. So with that, Tom, I'm going to turn it over to you.
Thank you, Gary. That was that was a perfect reading, and I'm just going to leave it like that, and couldn't agree more with those words. So thank you for sharing that. Between COVID and all the unrest over the last year, that this is a month where Black History Month means more than it ever did before, and more reflections like that are critical. I'd be remiss if I didn't have a shout out to folks in Texas, and one of our speakers today, Mohammed Siddique, is in Texas, and maybe he'll give us a couple of words about whether he has heat or running water. He looks like he had a shower, so he looks good. So we're very happy for him. But in all seriousness, I mean, you keep thinking about this year and what next, what could happen next, and this is quite a remarkable stress on top of multiple stressors. And our heart goes out to our colleagues in Texas, to their patients, to their families. I lived through Superstorm Sandy in New York, and the one thing that reminds me of Superstorm Sandy is that it's an emergency that happens suddenly, and both you and your families are terribly impacted, as is your patients and your work. So you have this dual struggle of showing up at work, yet being worried about your family. Do you have running water? Do you have electricity? Yet you got to show up and care for your patients. And it's that stress that can be so difficult. So, we're just, our thoughts and prayers go out to the folks in Texas. On a positive note, vaccine rollout really is hitting its legs in the ambulatory setting. Every market is doing this a little differently. Every market is really doing a better job. We will hopefully hit, I don't know, Gary, how close we're going to be to 100,000, but I think we're coming close. We're probably at 85, 90,000 by the end of next week. But we're going to hit that 100,000 mark across all of our markets. I mean, we're estimating that patients being seen in our practice sites is about 1.2 million. Our goal is to make sure we vaccinate all of them. And obviously, many of you are participating in community efforts to get the vaccines out into different large community events. So I just want to thank everybody for this effort. I'm going to continue to put pressure on everybody to vaccinate, vaccinate, vaccinate. We're going to have a turn here where it's suddenly going to morph into people banging on our doors to get their vaccine to us banging on their doors. And we need to look at the communities of color and others that have struggled to get the vaccine. Think about our geriatric patients who have mild cognitive impairment, who can't get out of their houses. We have to get to them. We have to figure out how to do that over the next few months. And that's going to be a shift in our thinking, is us going out to the community and getting them. All right, enough said. I want to introduce our speakers. I'm so happy to have two excellent speakers. I have Dr. Griffith Blackmon, who went to Hahnemann University and did a lot of his training at, is it the right way to say UW? Is that the right thing to say? One of the really great medical schools where he did his residency and his training in pulmonary critical care. He is currently the medical director of critical care services at St. Michael's Medical Center in Silverdale, Washington. So we're so happy to have him here. He's literally sitting in the ICU saving lives as we speak. After, I think first up though, we do have Dr. Siddique. Dr. Siddique did his medical school in King Edward Medical University in Lahore, Pakistan. It sounds like he did 2 residencies to me, which is always, if I'm right, and that's always fascinating for someone who comes from abroad and does that again. It's really a remarkable thing. So he did categorical internal medicine residency, both at the Khalid Aman Hospital and also at Rush in Chicago. He did his fellowship in pulmonary critical care sleep medicine in Southern Illinois, and he is currently at Baylor College of Medicine, where he is the assistant professor at Baylor and the medical director of ICU services at Baylor St. Luke's Medical Center, as well as the chief of the ICU services at Texas Children's Hospital Pavilion for Women. So, Dr. Siddique, I'm going to turn this over to you, and we look forward to hearing from you.
Thank you so much for the introduction, and thanks for the thoughts and prayers. We really need that. I can tell you, I lived in Illinois for a long time, and this is different. I mean, 2 inches of snow in Texas felt like 4 feet of snow in Illinois, because we're just not prepared. And we're just really worried about what's going to come next, as you said. And, we had this stadiums open for people to take shelter. So we're worried about social distancing is gone, and maybe we're going to have resurge of a lot of COVID patients. Most of the hemodialysis centers are without power and water. So a lot of patients are just showing up in our ED for emergency dialysis. So we need your thoughts and prayers. Thank you for that. So I'm going to start with the inpatient management of COVID-19. Can we go to the next slide? So no disclosures for this presentation. I chose this patient because this patient had it all. So it's just going to allow us to go through most of the management of COVID-19. It's a 45-year-old male with prediabetes, hypertension, who presented to the clinic with 3-day history of cough, fever, and mild shortness of breath. He had a recent exposure to a COVID-19 positive family member. His vitals were stable, except some tachycardia and a temperature of 100.5. His PCR was ordered, it was positive. A CBC was done. He had some leukocytosis, he had leukopenia. And then a chest X-ray, he had some ground glass opacities. Can you go to the next slide? So what is the treatment for this patient? I think you guys may have gone through the outpatient treatment, but briefly, it's just conservative management. You just use antipyretics. Steroids are not recommended because there has been no trial and these patients were excluded from the recovery trial. And the NIH guideline panel recommends against the use of steroids. There have been 2 randomized trials. They're small, and they suggest that anti-SARS-CoV-2 monoclonal antibodies may reduce the number of visits to ED and hospitalization, and they're available as EUA. We have used them, and we had some success, but every center has their own process for that. The next is remdesivir. So the trial done for remdesivir was for inpatient requiring oxygenation. So there has not been any trial for outpatient management. If you're COVID positive, there is an ongoing trial which should give us some more insight into this. And then the last one is NIH panel does not have any specific recommendation for or against it. There have been like only a few cases where we have treated outpatients with remdesivir because they have very severe comorbid conditions. There were some of our physicians who were dealing with a lot of patients and procedures. So we were able to give them remdesivir, but it was just like, you know, case by case basis. The general recommendation is not to use any antiviral medications. Next slide. So over the next 24 hours, patient's condition got worse. He had now high-grade fever. His cough has worsened, his shortness of breath has worsened. So he presented to the ED. He had temp of 1 or 2, tachycardic, slightly tachypnic, blood pressure on the lower side, saturating 84% on room air. He was started on nasal cannula, which was titrated up to 4 liters, and the SAT in low 90s. The physical exam was unremarkable, except vitals, which we talked about, and he was in some mild respiratory distress. In the labs, he had leukocytosis and he had lymphopenia and AKI with the creatinine of 1.1 with the baseline of 0.7. We have seen that quite a bit, where we have seen AKI in these patients, as well as transaminitis, some increased AST/ALT, which is common in this virus. We have a chest X-ray with ground glass opacities, which was slightly worse than his old chest X-ray, which was done as an outpatient. This was early in the second surge when this patient arrived. So at that time, we were doing CAT scans, but we don't do that anymore. But he had CAT scan, which was confirming the same. It was ground glass opacities. He was admitted to our COVID floor with airborne and contact isolation. Next slide. So this is a chest X-ray, again, as I mentioned, mainly increased interstitial markings, suggesting a ground glass opacities. Next, it should show the images of the CT scan. And again, it's just ground glass opacities, mainly right worse than left, but it's there. Next slide. So how should we treat this patient? So someone who is in the hospital now, he is on oxygen because of hypoxemia. So the NIH panel recommends remdesivir for patients who require minimal oxygen supplementation. And this is based on Act 1 trial, in which when remdesivir was given, the time to recovery in this group was 7 days compared to 9 days for placebo. And there was a lower percentage of disease progression, as well as a non-statistically significant trend towards reduced mortality. That's first recommendation. The second is, which most of the hospital will do, is a combination of dexamethasone and remdesivir for the patients who are on oxygen. So this is based on the recovery trial, the dexamethasone. There is a survival benefit in these subset of patients who are on oxygen. 23.3% of the participants died within 20 days of enrollment compared to 26.2%. The absolute reduction was close to 18%. Now, if for whatever reason, the remdesivir cannot be given, or there is a contraindication, for example, the creatinine clearance is less than 30, or there was a time in the surge 2 or 3 when we were very low on our supplies of remdesivir, then or what we used to do was just dexamethasone as based on the recovery trial. Next slide, please. So baricitinib plus remdesivir. This was based on the Act 2 trial, and there was some benefit. We have used this as emergency use authorization, maybe on one patient with severe DKA to a point where we could not use steroids. But other than that, we have only used it as part of the trial. We were cited for Act 1, 2, 3. So this is only for those patients where steroids cannot be given. In Texas Medical Center, there are some centers who have baricitinib as emergency use authorization, and they give it as part of the treatment, but not at our centers. The next is convalescent plasma. I know it's a hard topic. There have been conflicting data about it. There have been some recent articles saying that if you're able to give the convalescent plasma within 72 hours, there could be some potential benefit, but there have been large trials suggesting that there is no benefit, especially if it's given 6 to 7 days after the onset of the symptoms. At our center, we just treat it on case-to-case basis. This patient did not get it because it was already 4 days post, and that has been our practice as well. Ivermectin. Whenever I present, I always get this question about ivermectin. NIH says that there is insufficient data to recommend for or against it. They're very small trials. Some shows there is some benefit, some shows there is no benefit, but this is just based on the antiviral activity in vitro, but the levels that are required, you have to give very massive doses of it. So at our center, we have not been using it routinely. There have been like 1 or 2 cases where we have tried it, but it's not part of our process. Now at St. Luke's, we have different trials that we go through. For example, Remdecta trial, which is ongoing, which is remdesivir plus tocilizumab. So if someone can be enrolled in that, we try that. And then T-cell trial would have phase 1 study between 5 centers where we're trying that. An eSTIM study, so this patient was enrolled for that as well, which is just, we have realized that a lot of these patients get a lot of muscle weakness. So this is just electrical stimulation. We have found that their muscles are, in terms of recovery, is much better and the loss is much lower. Next slide, please. So just to summarize what we talked about, for non-hospitalized, there is no specific treatment. For hospitalized, not requiring any oxygen, again, no specific treatment, no recommendation for dexamethasone either. If you're hospitalized and are on oxygen, remdesivir, combination of remdesivir and dexamethasone, or dexamethasone and remdesivir cannot be given. And the same is for if you're requiring high flow oxygen or on mechanical ventilation. Now, on mechanical ventilation, the remdesivir EUA, emergency use authorization, would not be applicable because you're on the ventilator. So we don't do that. But on mechanical ventilator, if you had a study like we have Remdecta, then you can be enrolled on that trial. Next slide, please. So back to our patient. So his condition continued to get worse in spite of all we were doing. Now he's up to 6 liters. We also implement self-proning. We have a full protocol for that, where patients, if they're able to, they go on self-proning 2 hours and then they're back. We've seen some mild to modest improvement with that, but nothing really significant. And then we, keep checking on these patients every few hours. For this patient, few hours after he was started on 6 liters and self-proning, he was still having fever, which was high grade, still tachycardic, still hypoxic, now up to 6 liters. In our experience, when they were getting to this level, and specifically this rapid decline, we moved these patients to either a step-down unit or to ICU because we anticipate that their condition will get worse. And then we do that with a non-rebreather. So once this patient came into the ICU, he was placed on high-flow nasal cannula. There are different names for that, OptiFlow, Vapotherm. But then we used the highest flow, start with 100%, and then wean as tolerated. And then we continue to use the self-proning as well. In our centers, and I can share that if anyone is interested, we have a protocol based on D-dimer, CRP, and TEG, where we start people on subtherapeutic anticoagulation. So it's not therapeutic and it's not prophylactic either for these patients. Either we use heparin with a PTT target of 40 to 60, or we use Lovenox with 0.5 milligrams per kilo twice a day, specifically for the patients in the ICU. We're going to publish that. We have published some, preliminary data. There was no increased risk of bleeding with that, but the risk of thrombosis was very minimal. A lot of these patients had central lines, PICC lines, and things like that. Before we implemented this, we have to change the lines every day. But after this, it was much better. Next slide, please. So back to our patient. So he was on high flow oxygen, self-proning, but still not improving, still desaturating. So what next? There are two things that you can use. We use helmet more than BiPAP. Helmet is from a local company in Texas. It works as BiPAP, but it has both an inlet and an outlet, just like a ventilator. And we're able to titrate it. The risk of exposure to the healthcare workers is very limited as well, because it has an antiviral filter to it. And then you can adjust based on that. And then what we do is we alternate that with Vapotherm. Again, we had some good results with that. We're gonna publish that. We're just working on the analysis for that. And then, so we started on IPAP of 12, EPAP of 6, so you can get good tidal volume. His final settings were 22/10. Patient improved just a little bit. His saturations were better. He was still having tachypnea. Next slide, please. We follow this patient every few hours, every hour based on the nursing, and every few hours for physicians. And he was having decreased level of consciousness, which is one of the indication to intubate these people. That means they may not be able to handle their secretions well. So we intubated this patient. He was started on ARDS protocol based on the low tidal volume strategy. His saturations was still in low 80s. We started Flolan as well as paralytics, so we can get some benefit. With all these sedation and paralytics, his blood pressure dropped, so he ended up on pressors as well, and he was prone. And at this level in our institution, we have a protocol that we start looking for, is this patient going to be an ECMO candidate, and see if that can be of any benefit. Next slide, please. So this patient was deemed an ECMO candidate. He was on VV ECMO for about 12 days. He was decannulated after 12 days from ECMO. He was still on the ventilator. He received tracheostomy, got better, went to an LTAC. He stayed there for about 21 days, and then he was actually decannulated. Initially was a nasal cannula, and then he was weaned from nasal cannula. Was seen in clinic, pulmonary clinic. We have a post-COVID clinic as well, and he was actually doing really well. Still very weak, getting a lot of physical therapy, occupational therapy, but still back on his feet. And I believe he was a firefighter, so he cannot go to the job yet because of all the requirements that he had for lifting and things, but back with his family. Next slide, please. So just some take-home points. COVID-19 is a novel disease with very high morbidity and mortality. I have a full deck of slides where we actually had our data for March through December. Our mortality has been about mid-teens for overall, about 30% or so for ICU, and vent mortality about 40%, which is better compared to the national as well as international average, because we have worked more time to prepare for all this. For inpatients without oxygen requirement, there is no specific therapy. For patients who are hypoxemic, remdesivir, or combination of remdesivir plus tachydron would improve duration of symptoms and survival. Other therapies would include baricitinib, convalescent plasma, based on clinical situation. Hypoxemia is treated with nasal cannula. You can escalate to high flow, non-invasive, and then invasive ventilation based on clinical situation, and ECMO is needed. And again, ECMO therapy in specific situations. Again, it has to be single organ failure, and it has to be a young patient who can survive through this. Next slide, please. Some of the references, and again, I have a full slide deck with a lot of data. We'll upload it to the database, and then if someone had questions, we would have to answer them. Thank you so much.
Thank you. That's great. We're gonna hold questions. That is everything in one patient. That was absolutely great. So Griff, Dr. Blackmon, you're up.
All right, thanks. Did you get my slides, Gary?
Yes, and John has them.
Okay.
I think. Yeah, here we go. Nice picture.
Right, so thank you very much. Yes, I did spend a total of 8 years at the University of Washington in postgraduate training. And probably unlike Dr. Siddique, I eventually failed to get my grants funded. And that ended my academic career fairly abruptly. This is not the typical ferry ride in Puget Sound, but it does, I think, for many of us now, this is what COVID feels like. Next slide. So I'm going to give you just a quick view of the National Hospital Trends. This is from CommonSpirit Health data analytics people. Next slide. And this is just all U.S. COVID patients, and you can see, really, our initial bump and then 2-second surges that we're all familiar. Top line total hospitalized, the orange line ICU care, and the gray line ventilated patients. Next slide, please. And this is just acute census by division, and this is going to build hopefully, and you can see your own division and get a sense of what the acute care disease burden has been like. Next slide. So this should just auto-populate. This starts with Fargo, Northern California, Pacific Northwest, Greater Sacramento, California's Central Coast, Midwest, Southeast, Central California, Texas, Arizona, and then our fortunate friends in the Southwest. So as you can see, the disease burden across the different divisions has been quite disparate. Early on, I reassured my elderly father that I didn't think this COVID-19 was going to be the zombie apocalypse. But certainly in some places at some times, it certainly has, I think, approached that, particularly on the acute care side, overwhelmed EDs and ICUs. Next slide. So there's been really a lot of work done early on, and I'm just going to summarize that very quickly. So the CommonSpirit Health C5, which is CommonSpirit Health Clinical Critical Care Committee, and the coordinator is Brenda Downs, so shout out to her, started doing a lot of work early on. Next slide, please. And these are really things that were developed as resources across CommonSpirit Health by C5 early on, beginning with clinical management guidelines, an early consensus statement regarding multiple patients per ventilator. You may recall there was a lot of enthusiasm in the early days for ventilating multiple patients with one ventilator. I think there was probably a 3-week span where I was asked several times a day by a litany of well-meaning people if I had heard about the ability to use one ventilator to ventilate 2, 4, or more patients. We worked to secure additional ventilators to meet the need with surges, develop toolkits. Hood ventilation is a helmet ventilation that Dr. Siddique referenced, and they've done a ton of work down in Texas and really have provided a lot of resources across the country for CommonSpirit Health. So think of this as a plastic fishbowl that is inverted and placed on a person's head with a tight-fitting neck piece, and then we can deliver positive pressure ventilation through that interface. So as you can see, really a number of other projects that were worked on early on, including recommendations for tracheostomy, when, how, code blue, a lot of things around, trying to protect healthcare providers and aerosol generating procedures. Next slide, please. The other thing has been, I think, hugely helpful across the system has been the CommonSpirit COVID treatment guideline work group. And this has been in large part through pharmacy and therapeutics, but been collaborative with infectious disease and critical care and others. And they have published on about every 2-week cadence treatment guidelines that are disseminated across the enterprise. They're updated regularly by the team, and they're based largely on consensus NIH treatment guidelines. Next slide, please. So I'm going to give you just a quick run through at high level on sort of, what have we done and how have things evolved, and, what the future might hold with this. Like the challenge of this pandemic is, early on, we started seeing a lot of really sick people and they weren't doing well at all. And there really was, we saw a lot of sort of just throw everything at the wall and see what sticks. And it was well intended. And some of it worked, and some of it was hypothesis generating, and some of it didn't. I think one of the real challenges on the acute care side has been a complete change in how we disseminate medical information and scientific advances. So, this whole thing has moved way too fast for the classic peer review process. And it's, only really within the last, just few months that we've started to see substantive numbers of peer-reviewed studies. But, we've seen the rise of information conveyed by preprint servers like medRxiv, press releases, internet websites, Twitter accounts. It's really been quite remarkable, and sometimes difficult to sort through and separate the wheat from the chaff. There has been emergence, I think, of a number of credible and respected and reliable guidelines. And primarily the NIH treatment guidelines have proven useful, kind of at the front line, as well as guidelines published regularly and updated by the Infectious Disease Society of America. As well, Society of Critical Care Medicine has published guidelines early on that extend to all aspects of critical care, not just pharmacologic therapy. So early on, I'll recall hydroxychloroquine and runs on the pharmacy to secure this, and early enthusiasm for hydroxychloroquine primarily in combination with this azithromycin. Hydroxychloroquine modulates IL-1 and IL-6 predominantly and has some antiviral properties. Interesting, the early study that generated enthusiasm for the combination therapy is they were giving azithromycin just really to prophylax against secondary bacterial infections and saw increased viral clearance. The exact mechanism, I think, is still not entirely clear, but it generated a lot of enthusiasm. But as we all know, that really has fallen out of favor primarily due to concerns of adverse effects with respect to complications of QT prolongation. And when the dust all settled, really no convincing therapy that those drugs improved outcome. In a similar vein, there was a lot of early use of lopinavir and ritonavir, but as data was amassed, really did not prove to be an effective therapy. So these have, all been really largely abandoned. Next slide, please. Convalescent plasma had a lot of, very early enthusiasm. I thought there was sort of a, historical irony that that's what we used with the last great pandemic in 1918. So 100 years transpire and we're going to the same playbook. At this point, I think it's clear that, as Dr. Siddique's case noted, best use early in the disease course and higher titer units are preferred. There have been actually some difficulties. The assays that have been specified to determine titers are not widely available. So there are many blood programs around the country that actually can't label their units as high titer, even though they may be, because they don't have access to the designated assay. It was still probably has some value, but not routinely used. And again, probably best used early in the course of disease. Next slide, please. So this is where we are current, and Dr. Siddique is going to probably get some heartburn on tocilizumab, but I'll get to that in a second. So at this point, really is consensus that in the hospitalized patient, remdesivir, dexamethasone baricitinib only if steroids are contraindicated, not universally available, but that's is an alternative. Tocilizumab has had a lot of interest since early on as an IL-6 receptor antagonist. And I put it on the list really just reflecting data out of the recovery trial that was released just within the past week that showed significant improvements in survival. I think it's likely that we will see some consensus recommendations regarding tocilizumab in the coming weeks, but we'll wait and see. The recovery trial used a CRP threshold for enrollment, and I think that does provide us some useful guidance. And the other thing of the recovery trial that I think is different from many of the previous trials that have yielded conflicting results with tocilizumab is that the majority, I think about 88% of those patients were on steroids as well. And the combination of therapy is probably important. The other thing is many of the early studies use tocilizumab as rescue therapy. So, maybe disinclined to find benefit under, really severe circumstances. And then the last thing that really is current standard therapy, but not directed directly at the virus or the inflammatory cascade, is DVT prophylaxis. It's very clear that prophylaxis with enoxaparin or heparin reduces the risk. High intensity prophylaxis, as Dr. Siddique noted, is becoming increasingly prevalent. And I would say, at least in the Pacific Northwest, probably the majority of our patients are anticoagulated with a higher intensity prophylaxis, usually with enoxaparin dosed twice daily. And then therapeutic anticoagulation or low intensity therapeutic anticoagulation certainly been used. We as well have encountered lots of difficulties with catheters clotting, primarily dialysis catheters with CRRT, and been in a position where we're changing lines on a daily basis. And in those cases, low intensity therapeutic anticoagulation has more or less resolved those issues. Next slide, please. So sort of therapies with persistent interest, ivermectin continues to kick around and I think remains to be validated. The biggest problem, even though there is in vitro evidence it's effective, as Dr. Siddique noted, it's very difficult to achieve in vivo concentrations with antiviral effect. And then the last, neutralizing antibodies, and I bring this to this group because this is really, I think, at the interface between the ambulatory and the acute care setting. And I think that's where these have the greatest value. The trick is, of course, is to capture these patients and then to have a system where infusion can be done. And one of the challenges, I think every place is where can we do this? Many existing infusion centers are not set up to quarantine patients or isolate patients. And then certainly, I think many places, ourselves included, have real difficulties with staffing. But we are actually trying to stand up a pilot project here in the Pacific Northwest, working with the outpatient pulmonary clinics. Next slide, please. And then just very quickly, the fundamentals of non-pharmacologic therapy. And once a patient becomes ill, high flow nasal cannula may transition to non-invasive ventilation, either by BiPAP or by a hood interface, and then eventually invasive ventilation. But we would hope to avoid that, as if the patient gets that sick, the outcomes are not great. Prone positioning early on with self-proning is widely used and is effective. And then once a patient is invasively ventilated, most places do a lot of prone ventilation. As in sort of general ARDS, those benefits seem to be somewhat transitory, but they certainly can improve oxygenation, particularly in the first few days, and can sometimes help get the patient over the hump. Conservative fluid management is hugely important, trying to avoid fluid overload. And then there's a high incidence once a patient is critically ill of acute renal failure and some sort of dialysis support, CRRT or whatever you have available is often a big part of the therapy. And then in places where ECMO is available, that's obviously the last heroic intervention. Most ECMO centers have fairly stringent criteria about entry, really not wanting to take patients who have low probability of survival. The trick is that a patient who gets sick quickly and identify them fairly quickly and then making a referral for ECMO. We do not have ECMO actually within our CommonSpirit facilities here in the Pacific Northwest. We have to refer outside. One of the challenges is can we make the call, get it set up, and get the patient moved before they're too sick to travel. Next slide. That might be it. Yeah, that's all I've got.
Great. Thank you both. That's great. Now, Brooke Burgess, I just texted you to see or John, if there are questions in my chat box and Q&A. I don't see any questions, but I think that's because it's limited to the panel for some reason. But
yeah, I don't see any either, Gary.
Yeah, we have something happened this morning with the way this got set up, but I do have a few, and one question I would have is, could you both talk a little bit about proning and all of a sudden about 3 or 4 months into this, people sort of realize that, wow, this proning saves a lot of lives and keeps people off of ventilators and so forth. And Griff, I think you mentioned applicability in the ambulatory space, and could you talk a little bit about the pathophysiology and B, how that might be applied in an ambulatory setting?
Yeah, well, I'm actually probably, Dr. Siddique probably has had more practice describing the pathophysiology and why proning works. But the short story is that we're improving ventilation perfusion matching in the lung, generally because we're sort of taking dependent atelectasis or dependent airspace disease out of the equation when we flip the patient over. Prone ventilation has been well recognized as effective in acute lung injury and ARDS for a long time. And fortunately, fairly early on, some people, fairly clever people, looking at the CT scans, looking at these ground glass opacities, said, listen, why don't we try flipping people and doing it early in patients who are admitted to our inpatient hospitalist service with even relatively low oxygen requirements. We too have a self-proning policy, as described, I think, by a pediatric intensivist who rotated through one of our hospitals. It's tummy time, and it's effective.
I would echo the same. Again, we have more experience here because we have developed proning team for ventilated patients, and then we have processes for awake patient who are just in oxygen, even on the hood. Again, it's just taking the dependent atelectasis out of the way. There's some hypothesis that maybe it's gravitational, and then flipping them to the tummy is just going to improve the VQ mismatch. But I think we just have to be careful. I've seen where people are just dependent a lot on proning, and they're delaying, escalating the therapies, whether it's like BiPAP or even ventilation. I mean, this is just going to buy you some time, and that could be the first few, days. But then if it's just not improving, then we just have to escalate to the next. There is some modest increase. There's some patients who just cannot do it because they're just so weak. And then especially in ventilated patients, we have created these teams who are just trying to do it safely. We have special devices that can be placed, because one thing that is coming out of it, especially from the first surge, was that a lot of people are developing deep tissue injury on their face. So we have changed like the way we're putting the ET tubes, the ET tube holders. We're using some special devices that anesthesia uses in the OR just to minimize that. So to summarize, there is hypothesis that it increases, some modest increase, especially early on, but that should not be implied to delay the therapy.
Yeah, absolutely.
Okay, I'm going to ask one more question and then we're going to finish. And Dr. Siddique, you mentioned your anticoagulation protocol and improvement in thrombosis. And right now, I know there are trials, but there are no recommendations for ambulatory anticoagulation. And do either of you see that changing, either for sick ambulatory high risk patients or for people who are exiting the hospital but have been anticoagulated there, not for atrial fib and those sorts of things, but because of COVID?
So I'm not aware of any trial. There could be some through NIH. I have to look at it. But what we noticed, so early on, there were some patients who were improving, and then all of a sudden I got called because they're decompensating, and we use point of care ultrasound, and we call it the RV's blown, which means that all of a sudden their RV just went into failure, probably because of microthrombi. Ever since we started using anticoagulation, we have not seen that, as well as improvement with thrombosis of the lines. We have, again, this is not a recommendation, but we have a group of experts from within Baylor and different from TMC with Methodist, UT, and others. And we decided that if someone is sick, who's on the ventilator for quite a bit of time, they're going to be weak and cannot ambulate. We generally tend to anticoagulate them for a total of 3 weeks. Mm-hmm. And then if they're going home after 2 weeks, then we either use Lovenox or one of the DOACs that they can take home. We have not seen any bleeding complications from that, but this is just, based on our local experience. I'm not sure that if we would have some recommendation coming soon, because it needs testing and trials.
Okay, Griff, any comments?
No, I would agree. I think it's a very reasonable strategy, transitioning out of the acute care, particularly the critical care setting. I think the question of, is there a role for anticoagulation in the ambulatory setting in a patient who never gets sick enough to be hospitalized is a really very interesting one. And I don't think we know the answer yet. I think we're getting increasing understanding of long-term sequelae of
Yes.
COVID-19, much of which is probably related to microthrombotic disease. So I think there's compelling reason to investigate that, but I don't think we have that answer at this point.
All right. Well, I want to. We did get a couple of comments, and there's one question that we'll follow up on offline about tocilizumab and send out the answer. But I want to thank both of you. Great. We as you know, have focused in the ambulatory space, and so I think for folks who are in the house, this is great information, and for all of us, I'm in the ambulatory space as well. But I think it's really helpful to sort of see the progress. See what happened to this patient, Dr. Siddique. That was amazing. And so I really do appreciate it. And I think I can always tell how our sessions are going by who stays on the line. And basically, I can tell you that everyone who started the call is still on. So that's a good sign. So thank you both. We'll have some follow-up. Griff, you probably need to go home and get some sleep if I'm reading the tea leaves right.
Well, no, actually, I was here late last night and early this morning, but I'm actually the daytime guy, so I got to go.
Oh, gosh. You probably have to go. Thank you both. Our prayers are definitely with you, and thoughts in Texas for your family and for all those families that are struggling down there. And we hope things get better as the weekend progresses. I want to thank everyone, and we'll be back in 2 weeks, and we will be talking thrombotic disease, number 1, and number 2, we're going to look at how we can recalendar some of this to be sure that we can get the needs of everyone met. So thanks, appreciate it. Have a great weekend and a safe weekend, everybody.